All right, so you guys, we're going to do a lecture real quick. It's Don't Blow Me Off, a how-to guide for the use of ventilators. And then after we do this lecture, we'll do a ventilator lab. So we'll run through the Ravel, which is the ventilator that you guys use for critical care transport. So we're going to review terminology related to mechanical ventilation. We're going to differentiate between CPAP and BPAP. We're going to describe ventilator settings in patients with multiple pathologies, so we'll run through those, and then we'll demonstrate how to troubleshoot a mechanical ventilator in an emergency setting where you guys would use it. So I'm not going to talk about a whole lot about trigger. Trigger is pretty much based upon pressure or flow. So the ventilator, depending on which trigger it's using or what type of ventilator it is, determines the pressure, and that's how it delivers a decrease in the amount of pressure, and then it'll deliver a breath based upon that, or the flow, so it'll reach a certain flow and then deliver a breath upon that. So but what I will talk about a lot is all this terminology, and we're going to do this, some of it kind of individually, but let's run through some of it kind of closely. So ventilation is just the act of moving air into and out of the lungs, right? I mean, it's not something that we're going to talk about a whole lot about. I mean, that's obviously what we're going to do for this, but other than that, it's not super technical. Tidal volume is something that we do talk about fairly frequently. So when I started in the intensive care units, we did a lot of tidal volume. We did 10 to 15 mLs per kilogram on a lot of our patients. And what we found associated with that was a lot of baro and volume trauma and ARDS in the Nang lung, or whatever you wanted to call it, and increase in mortality and morbidity associated with it. What do you guys do today? What's a normal tidal volume for a patient? 6 to 8 cc's per kilogram is what you usually give to a person. And a tidal volume, you guys, is just the air on a normal inspiration that you would take right now. So it's not anything greater than that. So it's just you guys all just take a breath for me. Just that's a normal tidal volume right there. It's not a that's not a normal tidal volume. It's just a normal inspiration. Minute ventilation we'll talk about here a little bit in greater depth. Peak inspiratory pressure we'll talk about here in a little bit also. Mean airway pressure, your plateau pressure, your fraction of inspired oxygen, and your inspiratory and expiratory times. We're going to talk about that here in a little bit. So again, just a normal tidal volume is just a normal inspiration there. It's not that extra little bit that you're given. So just a normal tidal volume, 6 to 8 cc's, and that's just the active ventilation of moving air into and out of the lungs. So let's talk about minute ventilation. So minute ventilation is kind of like what I like to think of as like the ventilatory part of a cardiac output. Cardiac output is heart rate times stroke volume. Minute ventilation is your respiratory rate times your tidal volume, right? And a normal minute ventilation for most of us is somewhere around 6 to 11 liters per minute. What I think is more important about minute ventilation than having a normal is knowing that minute ventilation is inversely related to in-tidal CO2 or PaCO2 on your gas, right? So if I've got somebody who is, let's say they're a traumatic brain injury, and I want to keep their in-tidal CO2 between 35 and 45 millimeters of mercury, I can titrate my minute ventilation to match that up, okay? So let's say their in-tidal CO2 is high, right? What would you do to your minute ventilation? Yeah, you would increase it to blow it off, right? So I would increase either my respiratory rate, probably primarily do that first, or my tidal volume to blow them down, right? So if I had an in-tidal CO2 of 48, right, and my respiratory rate was set at 10, then I would increase my respiratory rate to 12 to titrate or blow off my in-tidal CO2. Same thing if I was hypoventilating. So say my end tidal CO2 was 28, then what would you guys do with your minute ventilation? Yeah, so I would decrease it to increase my end tidal CO2. And so that is something that you guys will commonly do with your ventilator or doing a critical care transport, is titrate your minute ventilation to obtain an end tidal CO2. So peak inspiratory pressure is the maximum of pressure, is the highest or maximum level of pressure applied during the lungs during inhalation. A normal peak inspiratory pressure shouldn't be greater than 40 chronically, all right? And so what I mean by that is occasionally somebody can have an increased peak inspiratory pressure based upon certain things. So what would cause an increased peak inspiratory pressure? You guys tell me. Mucus plug would cause it, right? So chronically shouldn't occur, right? Because what are you doing with it? You're suctioning that mucus plug out, or they're coughing it up, or whatever, right? What else could cause an increase in your peak inspiratory pressure?
Anything that would affect the stiffness of the lungs, so pneumo.
Okay, and pneumothorax could cause an increased peak inspiratory pressure. Anything else you could think of? Kink tubing, yeah. So somebody's got their foot on the circuit, or the endotracheal tube is kinked. Somebody coughs, you know, they're waking up, pain, anxiety, agitation, coughing. They're trying to breathe against the ventilator, right? So, you know, in our last lecture, we talked about keeping somebody paralyzed, right? So you guys are transporting this guy down to the U, and all of a sudden he's waking up and he's coughing and he's agitated. It tells me that maybe I need to give him some Versed, some fentanyl, and possibly a paralytic to make sure that I've got good synchrony with the ventilator, right? So he's not coughing or breathing against the ventilation effort. So a peak inspiratory pressure that's chronically greater than 40 requires me definitely to investigate it and figure out what's going on. And really, you know, any increase in your peak inspiratory pressure, you need to figure out what's going on with it and try and investigate it. Peak inspiratory pressures measure the pressure in the large airways, right? So it's not the terminal airways, it's the large airways. So I think about some kind of increase in pressure in my bronchioles, my trachea, my endotracheal tube, you know, my circuit, something like that is causing an increase in my pressure for one reason or another. So I think peak inspiratory pressure, large airways, and it's the greatest amount of pressure applied during inhalation is the definition of my peak inspiratory pressure. My mean airway pressure is just an average, right? So it's the average, and you guys can see here where they cut it in half right there. So it's the average pressure applied during inhalation and exhalation during the ventilatory effort right there. And again, normal is somewhere between 6 and 11, 8, somewhere right around in there. And it's just averaging my pressure. My plateau pressure is a very important pressure to look at. And there's certain conditions where I'm going to be more prone to monitor it, but really anybody who is intubated, we should really look at our plateau pressure. And you can see my peak inspiratory pressure is here, my P-plat is right there, it's my plateau pressure. The plateau pressure is the average alveolar pressure during the inspiratory phase. And so it's looking at the terminal airways is where my plateau pressure is looking at. And so, Mark, you said a stiff lung, right? So this is where, this is the parameter that I'm really looking at in a few different patients that I'm concerned about having pressure in the terminal airways. So who would those patients be? I mean, where am I really concerned about my plateau pressure? I mean, honestly, I'm trying to get people to check a plateau pressure on every patient that is intubated, and I'll show you guys how to do that in our lab. I think it's important to check it and document it in every intubated patient. But where Is it very, where should I really look for it at?
Bronchospasm.
So bronchospasm, I would think more of who? Who would I think my level would be higher in a bronchospasm? My PIP, right? My peak inspiratory pressure, right? ARDS, yeah. So ARDS, ARDS, systemic inflammatory response syndrome, any of those kind of patients, I really would want to look at my P flat, right? So it could indicate that my patient has acute respiratory distress syndrome because it's pressure in the terminal airways or the alveolar membranes is what I'm worried about. So those are the patients that I'm really concerned about having a high P flat on. And a P flat is usually about 5 less than my peak inspiratory pressure. So a normal P flat is less than 35 millimeters of mercury is a normal plateau pressure. And I'll show you guys how to check that. And again, it should be, in my opinion, really checked on any intubated patient. And we'll get into some, when we get into troubleshooting and different disease conditions on where my peak inspiratory pressure will be and my P flat and all of those kind of things. So we're not done with it. We'll get back to it here in a little bit. So I think, you know, when you talk about intubating somebody and putting them on a ventilator, and when you're new to ventilation, you really just need to go through some general concepts of things. And so that's what I'm going to try and do right now. And so we're going to talk about volume versus pressure. So in volume mode, volume control, the tidal volume is constant for every breath. Pressure is allowed to vary over the course of ventilation. So what that means, you guys, is that if I set a volume on you, so we set a normal tidal volume that we're going to set as what? 6 to 8 cc's per kilogram, right? And let's have, we've got a 70 kilogram patient, so what's your tidal volume going to be? 560, right? So let's say we set a tidal volume of 500 on this patient, right? So what the ventilator is going to do is it's going to deliver a tidal volume of 500, right? It doesn't really care about the pressure that it gives to do that, right? It might be a peak inspiratory pressure of 42, it might be one of 38, it might be one of 56, it doesn't matter. And so I'm very cognizant of watching my pressures with that patient, right? So I want to see what my pressures are that that the ventilator has to achieve to deliver that volume of 500 cc's, right? Do you guys get it? So it's going to deliver 500 despite the pressure. So does that make sense with volume control? So again, I set the volume and the ventilator delivers that volume and it just gives it despite the pressure, okay? Pressure control is the same pressure throughout inspiration is given, so tidal volume is allowed to vary, right? So I set the pressure. So I say, hey, I want to give a pressure of 15 or whatever, and then it's going to deliver a volume up until that pressure, okay? So I don't know what the volume is going to be. It's just going to give it up until that pressure is achieved, and that's when it's going to stop with the volume that it gives, right? So again, you know, it might give a volume of 8 cc's per kilo, it might give a volume of 6 cc's per kilo, it might give a volume of 4 cc's per kilo. It depends upon how compliant the lung is and the pressure that I'm giving to deliver that volume, right? And so when I put somebody on a pressure control mode of ventilation, I'm very cognizant of my expiratory tidal volume. And usually when I use pressure control mode of ventilation, it's somebody who's got a stiff lung, and I set that pressure to give somewhere around 6 cc's per kilo. So I look at my expiratory tidal volume, and I say I really want to give 500, and I'm looking to give about 500 based upon my expiratory tidal volume, what I'm getting out. And so that's where I'll set my pressure to obtain that. Does that make sense to you guys? went through volume versus pressure. Now what I want to talk about real quick is just some modes of ventilation. The last one is kind of a breath mode, but some modes of ventilation. So CMV is a type of mechanical ventilation that you don't see anymore. It's called complete mechanical ventilation. You don't see it any longer in the ICU. Sometimes you'll see it in the OR, but it's taking over all parameters of ventilation. It runs everything for you, and we don't see that very often anymore at all. We do see assist control, and assist control is the closest thing that we have available today to complete mechanical ventilation. So here's what assist control mode of ventilation does. I set a rate. And I'm going to use the example first of a volume mode of assist control. All right. So I set a rate, I set a tidal volume, I set a peak, I set an FiO2 on the patient. It gives that for every ventilation. So let's say I've got a ventilatory rate of 12 breaths per minute. Okay. My patient is taking 14 breaths per minute. Okay. My tidal volume that I have set for those 12 breaths is 500 mLs. So it's going to give 500 mLs for all 12 ventilations. On the 13th ventilation, it's going to give 500 mLs. On the 14th ventilation, it's going to give 500 mLs. So every breath that the patient takes, whether it be me driving it or them driving it, it is going to give what I have set for the patient. Does that make sense? So every breath that the patient takes, it has the parameter that I have set. Synchronized intermittent mechanical ventilation is another mode of ventilation that you guys have available to you on the Revel. And what it does is it allows the patient to take their own breath. So again, using a volume mode of ventilation as an example, I've got it set up to deliver 12 breaths at 500 mils. So at 12 breaths, it's going to give 500 mils. At the 13th breath the patient decides to take, he or she can take whatever volume they want. So let's say they only want 250, or let's say they want 300, then they can take that, okay? They don't get that 500 per ventilation. So on assist control, you know, he triggers a breath with a, it's going to give him the 500. On SIMV, he triggers the 13th breath, and he's able to take in whatever he wants at that point. Does that work for you guys? Pressure support is not a mode of ventilation. It's more a mode of weaning or a mode of support. And what pressure support does for us in the transport setting is it allows the patient to take a breath without fighting all of the dead space. So if I have somebody on synchronized intermittent mechanical ventilation, and again I have them set at 12 breaths per minute, and they're taking 13 or 14 breaths, and they only want to take 250 or 300, I want to allow them to at least take the 250 or 300 and not have to fight the whole circuit, right? So I'm going to give at least 10 of pressure support. So any patient on SIMV, I'd put them on 10 of pressure support so they don't have to fight the whole circuit. Does that make sense to you guys? So that way if they want to take 300, they can get 300. Or they want to take 250, they can take 250 without having to fight the entire circuit, right? If you're not giving them any pressure support on SIMV, you're increasing the chance of them tiring out and wearing down and having to fight that ventilator to take those extra efforts that they want to have. Pressure regulated volume control is not a mode of ventilation, it's a breath mode is what it is. And pressure regulated volume control is kind of the best of both worlds. So what it allows me to do, it allows me to set a volume and a pressure, and then hopefully what I'm able to do is deliver that volume within that pressure, but it's going to regulate it. So it's going to say, man, you got your pressure set at 30 and you want 500, but I'm only able to get in 420, all right? So it's going to regulate it is what it's going to do. So hopefully I'm able to do kind of the best of both worlds with with pressure and volume with PRVC, but it regulates it for me. And I'll show you guys some pictures here, which will hopefully help you make sense of it a little bit. So what we have here, you guys, is we have got a picture, a graphic representation of somebody on assist control mode of ventilation, right? And so what I have done is I've set everything for them. I've set all the parameters for them. And so he's breathing, let's say 10, 11, and then let's say I've got the ventilatory rate set at 12. So let's say this is 11, this is 12, and he decides to take a 13th breath right here, okay? This is a ventilator triggered, or excuse me, a patient triggered ventilation right here. You guys can see that, where the pressure changed a little bit right there. And then this is a ventilator triggered breath. But you guys can see how everything is the same right there, right? So it doesn't matter if I had it set at volume or pressure, it's delivering the same thing regardless. That is assist control mode of ventilation, a graphic representation of it. So he takes a breath, it gives him the volume that I have triggered. He doesn't take a breath, the ventilator triggers it, he gets the volume that I have triggered, right? That I have set. So if I've got 750 set, he gets it whether he triggered it or the ventilator gives it. Does that make sense? All right, this is a graphic representation of synchronized intermittent mechanical ventilation. And so what's happening, you guys, is he is triggering a breath right here, and it's giving him, or excuse me, the ventilator is giving him a breath right here, and it's giving the volume that I have set. Right here, he's triggering a ventilation, right? So he's trying to take in a little breath right there, and it's allowing him to take in the volume that he wants. So let's say I've got him set at 750, and he wants 200, he's taking in 200 right there, all right? But he doesn't have any pressure support associated with this breath right now, so he's having to fight that whole vent circuit to do that. So you can understand where the patient could tire out a little bit with this, can't you? Because he doesn't have the ability to not fight all that circuit. You've got all that dead space, that endotracheal tube, and all that dead space attached to him. So right there, he does not have any pressure support associated with it. So what you've done here is you've added a little pressure support to him. So again, you know, the ventilator gives him the pressure and the volume or whatever I have set, depending on if it's a pressure control or a volume control mode of ventilation, and then all of a sudden he decides to take in his own ventilatory effort at this point, and so now you've got a little pressure support with it, so he doesn't have to fight that whole circuit. So I set him up with a tidal volume of 500, a rate of 12, and he decides to breathe 13 and 14 times. I've got 10 of pressure support associated with it, so he doesn't have to fight that whole circuit.
Isn't he also taking the breath like before and after because it has a little down on the pressure?
Well, this is an indication of a change in pressure, so it could just be a pressure trigger instead of a flow trigger. I don't know what the picture represents. So this is a graphic representation of pressure regulated volume control, and you can see you got your pressure and your volume right here, and so it's maxing out to a pressure, but it's only delivering the volume that it can in that point, right? So what I'm going to do in a pressure regulated volume control is I'm going to set my pressure, I'm going to set my volume, and hopefully I'm able to obtain both. But if it maxes out on a pressure, it's only going to give the volume that it can at that point. Pressure regulated volume control is a great lung protective mode of ventilation on somebody. So I've got somebody who I think might have acute respiratory distress syndrome, or they're stiff lungs for one reason or another. Pressure regulated volume control would be a good way to go ahead and ventilate that patient. Pressure regulated volume control also does it over a few breaths, so it starts to determine what the pressure is and start to give that ventilatory effort. So in a pressure regulated volume control, If I'm going to do that, it's great to put it on the test lung before I start it on the patient. So if I know I'm going to go pick up a patient and I'm going to put them on PRVC, I might set up my parameters real quick before I'm pulling up into the ambulance bay and turn it on and let it go through those 3 or 4 breaths and then apply it to the patient after that. And that's something that CareFusion actually advocates for you to do. So you guys, just in summary, some advantages and disadvantages of different modes of ventilation. So assist control volume guarantees a set delivery of the tidal volume. So you know that every breath you're going to give with assist control, you're going to get in 500. Is that what you plugged into the ventilator? But because the patient gets 500 regardless, it might lead to some hyperventilation, right? So, I mean, every breath he gets 500. I'm giving an increased minute ventilation, right? So I'm going to blow him off. Excessive inspiratory pressures you might see. Assist control pressure allows limitation of peak inspiratory pressure, but potential hyper or hypoventilation with lung compliance issues. Synchronized intermittent mechanical ventilation is great because it allows synchrony, but it also causes maybe possibly some increased workload for the patient, right? Because they're having to take their own ventilatory effort, and when they do, they don't get what you have plugged into it, and especially if you didn't give any pressure support. So it could lead to some hypoventilation. Pressure support allows weaning, and there's some variable patient tolerance associated with it. So let's talk about positive end expiratory pressure real quick. So PEEP, which you guys will have a PEEP valve in your CCT bag with your bag valve device, or you'll be able to allow or to administer positive end expiratory pressure on your ventilator, allows you to do a few things. And the big thing is it decreases shunting and also allows you to recruit alveoli. This is a picture that demonstrates no PEEP in A, optimal PEEP in B, and then C, too much PEEP. And too much PEEP is going to cause increase in interthoracic pressure and decrease in cardiac output associated with it. So it's important to get optimal levels of PEEP. According to our protocols, how much PEEP can you administer to a patient before you start to call in for medical control and all of that kind of stuff?
Isn't it 15?
Yeah, so if I was above 15, I definitely would start to call medical control. And really 10, I would be, starting to think, what's going on with them, right? And so what are some indications where you might use PEEP on somebody? Good. All right. Yeah. Good. So you might see somebody who you've got some auto PEEP associated with them, right? And did we talk about this in the last? Was there a question about pro PEEP the last lecture that we had? Oh, we had some. All right. So who might you see somebody with auto PEEP in? All right, so maybe chronic obstructive pulmonary disease, you might see auto PEEP, and really in any condition associated with an increased minute ventilation, right? So, so Jason, you said there were some things that Scott did to decrease or increase expiratory time, right? And so anything with increased minute ventilation, you might see some auto PEEP associated with it. So knowing that I might want to decrease my expiratory time, or increase my expiratory time in some of those patients, what's another condition that I might see auto PEEP in? Pneumothorax.
CHF or some sort of pulmonary edema maybe?
So I might see an auto PEEP in a CHF, especially if I gave too much PEEP to somebody. So if I gave, extrinsic PEEP, I gave too much extrinsic PEEP to somebody, I might start to see some rebreathing or some auto PEEPing in somebody for sure. And the one that I really think about is the asthmatic patient, right? So that's where I might see definitely some auto PEEP associated with ventilation in that patient. And in that patient, you know, I want to do a few things. Really with anybody with auto PEEP, I might want to do a few things. I might want to decrease the PEEP. I might want to match the auto PEEP. But I definitely want to prolong the expiratory time. And so we talked about ways to prolong the expiratory time in the last lecture that we had, but decreasing the I time and decreasing the respiratory rate will both increase expiratory time. And so those are things that I might want to do in a patient who I see auto PEEPing with. And you guys can see on your capnogram that the patient has auto PEEP. Do you guys see that? So your baseline, your line, this never comes down to 0, right? It's high. So that's an indication of auto PEEP right here. You guys see that? I might just take them off the ventilator for a second and allow them to breathe out, right? I might just unplug them for a second. I mean, what are some adverse effects of auto PEEP? Would you see hypotension? Yeah, because of increased interthoracic pressure, right? And decreased filling pressures. So I might increase my preload. So I might give this guy a fluid challenge. So I give him 500 cc's and see if that helps out a little bit, right? I might take him off the ventilator and allow him to breathe out to decrease that interthoracic pressure. I do all of these things, decrease my I time, decrease my respiratory time. And I would acknowledge the fact that I had auto PEEP based upon that capnogram. All right, let's talk about non-invasive positive pressure ventilation. So when we talk about non-invasive positive pressure ventilation, we talk about pressure support, CPAP, and BPAP. So, you know, I think, again, the main way that we use pressure support in critical care transport is we use it in conjunction with synchronized intermittent mechanical ventilation. And I think, you know, pressure support in the ICU today is used multiple different ways, and mainly as a way of weaning somebody. I bet you there's somebody in the ICU right now that they have got, they're waking him up, and they've got him on 10, 15 centimeters of water of pressure support, and they're attempting to wean him and see if they can extubate that patient. We, of course, don't do that in the transport setting. What we do with pressure support is we use pressure support to augment synchronized intermittent mechanical ventilation. And usually a pressure support of above 10 centimeters of water, you're starting to ventilate the patient. You're pushing now. But usually about 10 centimeters will help you to you know, combat the adverse effects of all that added dead space. CPAP and BPAP, I think, are probably the two scariest things there are for transport providers, in my opinion. So I've seen people freak out about this, transport providers, and I think with good reason. I think there's a lot of misunderstanding about both of these parameters, and you don't have a controlled airway any longer, do you? You're using a mask. And I'll never forget when CPAP first started to show itself in the transport environment. We had a respiratory therapist come talk to us about using CPAP in the field, and I was like, why? Like, I've got RSI. I don't need no CPAP, right? But CPAP has decreased mortality and morbidity amongst a certain group of patients, and BPAP can do the same thing for you. So here's some advantages and some disadvantages of using non-invasive modes of ventilation. So less sedation, patient able to maintain and verbalize, shorter hospital stays, early improvements in hypoxia, decreased rate of intubation, and decreased mortality. So I think all of those things are super advantageous to use non-invasive positive pressure ventilation. There's some adverse effects associated with it for sure also. Anxiety, agitation, decreased cardiac output, venous return, abdominal compartment syndrome, barotrauma and pneumothorax, and respiratory alkalosis. So you have to weigh out all of those very importantly before deciding whether or not you want to intubate somebody or put them on a non-invasive mode of ventilation. So here is a graphic representation of normal ventilation, which is the blue line, and continuous positive airway pressure. So CPAP, I know, is something that you guys use in the 911 environment. So CPAP delivers a continuous positive airway pressure throughout inspiration and expiration. You can see that it's the dashed line right there. So it's going to do it throughout inspiration and expiration, throughout the ventilatory cycle, deliver the same amount of pressure. Other than doing that, it doesn't change the aspects of ventilation other than that. That's all it does, is just delivers pressure throughout ventilation. CPAP, for a lack of better terms, is positive end expiratory pressure. It's PEEP for the most part. So knowing that CPAP is PEEP, what does CPAP do for you?
Increases that terminal airway pressures.
Okay. It would do that. What so what physiologic effects would it have on you? You have a patient. What kind of patient would you use CPAP on, I guess?
CHF.
Yeah. So a hypoxic emergency, right? So somebody who's got hypoxia is where I would use CPAP on, right? All right. Knowing that I would use it on a hypoxic failure or hypoxic emergency, that's a CHF patient is who I usually think of it as, congestive heart failure. And what do I want to do with those alveoli? I want to recruit more of them, right? I also want to push fluid out into the capillaries, right? So I want to push that fluid out. That's what PEEP allows me to do. I want to decrease shunting, don't I? Right? And I want to decrease preload. So it has all of those kind of effects. That's what CPAP does for you guys. All right, so it reduces shunting, prevents alveolar collapse, reduces preload, acts like PEEP. That's what CPAP is it's PEEP delivered via a mask and a machine. Okay? So when you guys are working 911, you don't have a PEEP valve on your bag valve mask, do you? But you got a CPAP, which is the same blasted thing for the most part. Okay? I mean, it's not, but it is. So CPAP is a lot like PEEP, and I show up at 2025 North College, and I've got a patient who's in a recliner chair, and they've got jugular venous distension, they've got hepatosplenomegalia, they've got pitting edema. You know, back in the old days, I'd nasally intubate that patient, right? But today, what I can do is provide them with CPAP, do all of these effects right here, probably reduce the chances of them putting on a ventilator, decrease mortality and morbidity with continuous positive airway pressure. That's CPAP. So used mainly for hypoxic diseases. All right. BPAP is different. All right. So BPAP or BiPAP, whatever you want to call it. BiPAP is a trade name, so it's really BPAP is what it's honestly called. So BPAP, we talked about CPAP is continuous positive airway pressure throughout inhalation and exhalation throughout the ventilatory effort. It's continuous pressure applied. It does not have a respiratory rate associated with it. I mean, BPAP, you could honestly say, is not a mode of non-invasive because it is an invasive mode of ventilation. BPAP has two distinct pressures associated with it. It has an inspiratory pressure and an expiratory pressure, an IPAP and an EPAP. And you guys can see right here, so I've got my EPAP and my IPAP. My tidal volume is the difference between the two. My EPAP is very similar to continuous positive airway pressure. All right, so it's going to do pretty much the same effects. It's going to reduce shunting. It's going to, prevent alveolar collapse, recruit alveoli. My IPAP is a driving force, so it's a little bit different. And so it has these two distinct pressures. The IPAP reduces workload and assures ventilation, decreases in-tidal CO2. The EPAP is, I put an equal sign, but it's very similar to CPAP, which is very similar to PEEP, and it reduces hypoxia. The tidal volume is the difference between the two of them. So knowing that my CPAP is used for a hypoxic respiratory emergency, where would I use BPAP? Which on the ambulance you guys don't have the ability to do, right? But in CCT you do, because you have a ventilator. So who would you use it for?
Or like your COPD.
COPD patient. Yeah. Yeah, asthmatic patient. Somebody who's hypercapnic, right? So somebody who's hypercapnic or hypoxic and hypercapnic.
I always wonder, how does the BiPAP work with the triggering mechanism? How does it know for inspiratory pressure and expiratory pressures? How does that work?
So it's either flow or pressure driven, depending on the ventilator that you have.
Mm-hmm.
So if the pressure changes, it says I need to give a breath. So it's giving an inspiratory pressure at that point. But it's keeping positive pressure during expiration too. There's your EPAP.
So BiPAP is always on a ventilator essentially?
Yeah.
Okay.
Yeah, so you can't hook it up to your wall.
Okay.
Yeah, no, it needs a ventilator to do it. Yeah, exactly. And I'll show you guys how to do BiPAP on your vent here in just a little bit. We'll go through that. So you guys will be able to do that. But, yeah, so if I had a COPDer, is CHF a good way to do it? You got, not CHF, gosh, no. Is CPAP a good way to ventilate that? I mean, you're not ventilating anyway with CPAP, right? You're just giving pressure throughout, right? But it's not going to help with your hypercapnia, CPAP, right? So all it's doing is help to recruit alveoli, prevent shunting, to reduce hypoxia. BPAP, on the other hand, is going to help reduce hypercapnia. So, I'll tell you, again, in my opinion, as a transport professional, people get very worked up with non-invasive mode of ventilation. Would you agree, Bert? Because, man, I can put a plastic tube in anybody and work my ventilator. Then it becomes much easier to do, I think, right? Or CPAP and BPAP, I think, are confusing to transport nurses and transport paramedics because we don't have that respiratory side of us. But I think knowing that BPAP is used for hypercapnia or mixed hypercapnia hypoxic emergencies, and CPAP is used for hypoxic emergencies is definitely useful for us. So there you go. So CPAP, ease of use. I mean, you guys use it on the ambulance today, right? And Josh, you said you have to have a ventilator for BPAP, right? So describe to me how you guys do CPAP in the ambulance.
You just plug it into...
It's a mask, right?
Yeah.
Yeah, so it's a mask that goes... Go ahead, continue.
Just plug it into high flow oxygen. It just is... it regulates at the tip for 10 centimeters of water.
And I've had flight professionals, I've had my team before, steal your mask up in Red Feather Lakes or whatever because they were confused with how to do CPAP on the ventilator. okay? So I'm going to teach you guys how to do it today, both BPAP and CPAP, so it's easier. And I've had people say, why don't we just buy those things, right? And I'm like, you don't need those things. You own this thing, which costs a lot more money, so why wouldn't you use this one? So yeah, exactly. So you just plug it in, and it gives 10 centimeters of water. Is that what it does? Yeah, there you go. All right, so I'll teach you guys how to do it via the ventilator. So it is super easy to use. It's supplied via face mask, improves hemodynamics, right? It lessens preload. That CHF is going to like that, right? Because that's a venous reservoir for blood, right? So you lessen that, and you're able to offload. Lessens hospital stay, may ward off intubation, used in hypoxia. BPAP, positive pressure during inspiration and expiration. Used in hypercapnia, or mixed hypoxic emergencies and hypercapnic emergencies. Familiarity, though, that's a big thing, right? Because I would tell you guys, again, I have, you know, people don't know when you use BPAP versus CPAP. They don't. You know, when I first started using it, when I worked at Airlife Denver years and years and years ago, I was like, BPAP is CPAP with a respiratory rate. It's not. It's not. They're different modes of non-invasive positive pressure ventilation. And for that matter, BPAP, you are kind of ventilating the patient. You're doing it via mask versus the endotracheal tube. So again, I just wanted to show you guys the graphic representations beside each other so you could appreciate that fact that CPAP is continuous positive airway pressure. It doesn't change. This is normal ventilation. This patient is normally breathing right here, and the pressure is just applied throughout ventilation, and it's applied for the purpose of opening up the alveoli, recruitment, and decreasing preload. Where BPAP is actually ventilating the patient, and you've got two distinct pressures associated with it, an inspiratory and an expiratory pressure. The expiratory pressure is very similar to CPAP or PEEP, whatever you want to call it, and the inspiratory pressure is the driving force, and that's going to help blow off your CO2. Knowing that, can I increase my IPAP to the point where I get increased intracranial pressure, or increased interthoracic pressure? Yeah, I can, right? And knowing that, what happens with that?
You get decreased preload.
And hypotension, right? Yeah. So man, I think back to a case I did when I was a CCT nurse one time, and I was like, man, I cannot frickin' my blood pressure is in the toilet, right? Because I kept on tick, 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 tick with my IPAP and really had a bunch of pressure, right? All right, hey guys, so we've talked about just some general concepts and terminology associated with ventilation. So we've talked about minute ventilation and how it's inversely related to end-tidal CO2 or PaCO2. We've talked about just ventilation. We've talked about peak inspiratory pressure. We've talked about plateau pressure. And we've talked about non-invasive modes of ventilation. And now what we're going to do real quickly is we're going to just set some patients up on the ventilator. Okay? So we're going to just go through settings. So these are the primary goals. And this is just what you should do with any patient that you're putting on a ventilator. You should always try and do all of this stuff. So optimize oxygenation and ventilation, avoid asynchrony, reduce their workload, avoid baro and volume trauma. And so any patient that I put on the ventilator, I should think about doing all of those kind of things. And we're going to go through your vent. I know probably, I know you guys and Mark, you just started, so you probably don't have a whole lot of experience touching these buttons yet, right? And then I know you guys are PRN. Have you had much of a practice with this thing yet? Or?
Not a whole lot. I still don't feel super comfortable.
Good. So our goal today will be to make you feel much more comfortable with how to set somebody up via CPAP, BPAP, SIMV, AC, volume, pressure, PRVC, whatever you want to do with this. We'll play with this thing today and hopefully get you much more comfortable with it. So, okay, this is most patients, right? This is most patients. So really, you guys, it's pretty friggin' easy. You know, Bert, would you agree with me? Does most everybody buys this? You know, I mean, occasionally you show up and it's some kind of funky, crazy arts patient or something like that. But in my years of doing transport, most patients are just this. It's not really too complicated. It's throw them on the ventilator and let's move, right? So tidal volume, 6 to 8 cc's per kilo. Rate, I'm going to titrate for an end-tidal CO2 between 35 and 45, because you guys know your minute ventilation and your end-tidal CO2, they go hand in hand, right? They're inversely related to each other. So I'm going to titrate my respiratory rate to maintain that. My I time, the time that my inspiration goes in over, about a second. Adults, 1 to 1.5. Pediatrics, 5 to 1. PEEP, set them up at 5. Maybe I'm having a hard time oxygenating them. I want to recruit some alveoli. So I go up to 7 or 8 or something like that. But I start out at 5, and I'm going to titrate my FiO2 to maintain a pulse ox of 94%. You know, you guys, here's what I do too, and this is just like a little cheat, is, you know, I have primary and secondary, right? And so let's say we're working together, Mark, and I'm going to be primary, you're going to be secondary. So primary, I'm going to take a report from the nurse. You're going to start getting them on all of the equipment and all that kind of stuff. You know what I want you to do first? Take the monitor, turn it on, take your end-tidal CO2 and plug it into their ventilator circuit. So now I'm getting an end-tidal CO2 off of what they're running, because I'm willing to bet that if you're picking them up out of the ER or the ICU, they're not on end-tidal CO2. They're just not, right? I'm willing to bet 9 times out of 10. Maybe they are, but there you go. And so I'm starting to see that, and I'm saying to myself, oh man, their end-tidal CO2 is 52, right? Now, there's times, and I'm not going to do a whole end-tidal CO2 lecture for you guys, but there's times where the end-tidal CO2 and the PA CO2 are vastly different, a lot of dead space or something like that, but let's say in this case they're not. So with those 52, what would I do with my ventilator? Would I run it at the same settings? No. What would I do with it? Or what else? Right. And I start with the rate generally.
Oh, you do?
Yeah. And here's the reason why, is because I don't want to cause volume trauma with the patient, right? So let's say the volume is at 8 cc's per kilogram. The rate's 12. I'm going to increase it to 14. Okay? Does that make sense to you guys? Yes.
Do you ever use that formula, end-tidal times
I don't.
respiratory rate divided by what you target?
No, I don't.
Just you go by
I've
two
heard of
or
it, but I
whatever.
don't use it.
Yeah.
But this is most everybody, you guys. This is pretty much everybody. This is 98% of the patients that I've ever moved on a ventilator are this setting. So I know people freak out about ventilators, but really it's this person is pretty much everything. Asthma. So the first question you have to ask yourself is, why in the heck did you intubate this patient? Because, man, you have just decided to jump on a roller coaster, right? So the first thing I'd say is like, whoa, what did we just do to ourselves, right? Why did you intubate the asthmatic?
Just any PEEP, usually.
So what was the indication? Why did you decide to intubate them?
Respiratory failure.
So I'll tell you what, man. You intubated them because they were obtunded. That was why you intubated them. It's the only reason you should intubate that kid, right? Or adult. Man, I would let them tolerate a pulse ox of 78% before I intubated that patient. I would not. Man, you are getting ready to ride a really steep ride if you decide to intubate that patient. They are rough patients to ventilate. Not horrible to intubate, right? Man, look at these split. Good job, Jace. You intubated them. Good job. But now, what are you ready to do to that patient after you intubate them? I'm ready to put in a chest tube, right? Because you're going to needle them and put in chest tubes left and right. and they're gonna auto PEEP, and they are gonna develop pneumothoraces. They are a complete mess, all right? I was talking to a flight nurse from Shands Care, and she said, this is the only patient that we have where we have to call medical control in before we intubate them. And that was powerful for me. I mean, Shands Care, you're talking University of Florida, right? That's a big program, a big, big transport program with a very vigorous pediatric side to it. And she has to call in to her pediatric intensivist before she can intubate an asthmatic patient. And so that would be the first thing I would ask myself is like, what did we just do? Man, that was a mistake. If you did intubate the asthmatic, what dissociative agent did you guys use? Ketamine. All right. So I would do a very small tidal volume on that patient. All right. I would decrease my respiratory rate and I would decrease my alt-I time, all in an effort to try and prolong my expiratory time. Your IE ratio, instead of being 1 to 2 normally, which I didn't talk about in inspiratory time, but your IE ratio 1 to 2, you're going to 1 to 4. You're trying to prolong that expiratory time. And PEEP is, you know, it used to be like super controversial. Like, do you give PEEP? Do you not give PEEP? But probably the best thing to do is try and figure out what your auto PEEP is and match it. So if my auto PEEP is 7, then you give them 7. If your auto PEEP is 10, you give them 10. And hypoxia and permissive hypercapnia may be acceptable. So if my end tidal CO2 is 48 and I'm 84%, probably happy with it. And honestly, guys, like again, like if I showed up and this kid's up in Risk Canyon and he's got a pulse ox at 84 and his side stream on his nasal cannula is 52, but he's awake, I'd fly him down. I'd give him a ton of albuterol and Atrovent and epinephrine and solumedrol and all that kind of stuff. And then I'd just fly him down here and hope that he doesn't need this later on, right? Because he's going to be a tricky, tricky mess. So do your best not to intubate him, but if you do, these are kind of the things that you want to do.
BiPAP by any time on that? Or?
Yeah, absolutely. So alternative setting right there. Yep, some BPAP on him, right? So, and I would do an inspiratory pressure at 8 to 10 and EPAP at 3 to 5. Slow his rate down again, right? So 8. But that would be good alternate settings. Yeah, good job, James. Right, exactly. Yeah, you got it, brother. With CPAP, this is the case where BPAP, you know, look, I was asked to try and sell ventilators to a bunch of EMS people one time, and it's hard. It's not easy to do, let me tell you. But Oklahoma bought a ton of them. Oklahoma Fire bought a ton of them. But it's not easy to do. But this is a case where BPAP is superior in the field than the CPAP. COPD would be also. But CHF, that's where nobody wants to buy them. They're like, yeah, we got our fancy little mask. You put that thing on. I'm like, well, it don't work in asthma. Well, so that's BPAP would be, yes.
And the reason CPAP is not good for this patient is because they're having trouble overcoming that 10 centimeters of water that you're just forcing in all the time, right?
Yeah.
So they're building up, they're air trapping and building up too much pressure.
Yeah.
I know, and EM Crit said that for obstructive airway management, say they are intubated to start off settings like they haven't been on a ventilator, you drop your PEEP to 0 or 3, just to initial and then match auto PEEP instead of starting at 5 in case they are lower. Or what?
For obstructive pulmonary disease?
Yeah.
Is that what he was saying? So
Yeah.
tell me again, say again, brother, I'm sorry.
Well, in initially setting up, say you don't have vent settings to go off of, just dropping that PEEP to make it easier because you're trying to promote exhalation.
Exhalation.
Obstruction.
Yeah, I mean, I guess in somebody with an obstructive pulmonary disease, it's probably not a bad idea to do. You know, I haven't listened to that one, to be honest with you. So, I mean, intrinsically, we all have PEEP. You and I all have 5 centimeters of PEEP right now. There's some cases where I'd be very worried about given PEEP, and that's usually like increased intracranial pressure. I haven't heard obstructive, but that makes sense. That makes sense. So, yeah, I definitely wouldn't give too much PEEP with those kind of patients because you worry about attention pneumothorax. Jace, did you have a question?
Yes, so for when we're setting this up on the vent and the IPAP is 8 to 10, are we talking about that being the pressure support or the initial, because isn't it additive?
It is additive.
So is the IPAP 8 to 10 in the pressure support way, or like when we're initially setting it
So
up?
I'm going to show you how to set it up so
Okay.
that it's less complicated for you. Does
Okay.
that work? So can we just save that until we do
Yeah,
our
yeah,
lab?
that's fine, I just
Yeah.
wanted to.
Yeah. No. Let me, so hold on to that, and when we set it up, hopefully I'll explain it to you and you'll be able to do it. Because I know it gets complicated. People get all worked up about it. We'll figure it out, so it will help you out. So, congestive heart failure, so, I don't know. It really isn't that much different than normal, in my opinion, right? So, so there you go. So I would do 6 to 8 cc's per kilo, 10 to 16, I time of 1, PEEP. I might give them a little bit more PEEP to drive that fluid. Titrate my pulse ox. It's really not anything that different than what you would normally do to anybody. My CPAP, put them on 10. There you go. You guys do these patients all the time. Acute respiratory distress syndrome. So ARDS is a bear, right? So acute respiratory distress syndrome is not a fun one. I can tell you guys out of 17 years of doing this that, my times of doing all of this kind of stuff is not very great. I would love to do more of them. I'm always jealous when somebody gets one. I'm like, damn it, why didn't I get that one? But it doesn't happen as often. And so again, I think the thing to know is that most often your patients are going to be normal settings, 6 to 8 cc's per kilogram, I time of 1. Rate 10 to 16 to titrate with an end-tidal CO2, titrate your FiO2 for a pulse ox greater than 94. But the ARDS one is the one that, we get paid for, right? So this is the one that you're gonna really work your butt off. So, how do you guys want to do this? So, this comes from ARDSnet. This is ARDSnet. And realize that this is initial settings, and you're gonna want to do some different things to it. So, my tidal volume, 8 mLs per kilo for predicted body weight, right? And you guys all have those cards, correct, that has the predicted body weight? No, so Mark, you need to get one. So, so in the little AirLink cheat book, there's a thing right there that says predicted body weight. And so I would use that, right? Because just because I'm 120 kilograms doesn't mean my lungs are any longer, right? They're still the same lungs that they would be if I were 60 kilograms. So I'm going to use an 8 ml per kilo predicted body weight. But it says over a period of less than 4 hours, I'm going to titrate the tidal volume to 4, 6, it could be as low as 4 mLs per kilogram for that patient, right? So 7, 6, 4, blah, 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 blah. My rate should be set to maintain a minute ventilation between 7 to 9 liters per minute. And the initial rate they start out at is a 35 breaths per minute, quick, right? So I'm breathing in pretty fast. My I time over about a second. My PEEP, I set it at 5, but more than likely I'm going to go much higher. And a trick that I've had in the past is I might increase it to like 20 just for about 4 or 5 breaths, maybe a maximum of 10, just to try and recruit and grab some alveoli to oxygenate them as best as I possibly can. My goal should be to decrease my oxygen and maintain an FiO2 of 70% or less to prevent the harmful effects of oxygen on the lungs. A sick patient, right? So how do I know they've got ARDS? Well, you guys are doing interfacility transports and you show up and he's got this non-cardiogenic pulmonary edema, right? So it tells me that his heart's working fine, and he's got a non-cardiogenic pulmonary edema, and he's got these alveolar and interstitial infiltrates throughout, that ground glass appearance, then he's got acute respiratory distress syndrome, right? And it could be secondary to a number of different causes, right? Maybe he's septic, maybe he's status post big trauma, or I don't know what's wrong with him, but there's something causing acute respiratory distress syndrome with this patient. I always like to do an acute lung injury score too. So any patient that I have on a blood gas, or that I can obtain a blood gas from, I always divide their PaO2 divided by their FiO2, and if it's less than 200, then it's severe, right? Then he's got acute respiratory distress syndrome, right? You know, 200 to 300 would be moderate, 300 to 400, you know, above 400 is normal, but I would say, you know, 300 would be minimal, somewhere around there. But, you know, you just take your PaO2 divided by your FiO2, and then you know FiO2 is your fracture of inspired oxygen, so 100 would be 1. You guys, any questions about settings? Is all good? So I think for the most part, man, it's really pretty simple. I think for the most part, the thing that gets most people is non-invasive modes of ventilation tend to be quite anxiety producing for a number of people. I think that, you know, I think if you have somebody that is, you know, a head injury, or you know, a status post cardiac arrest or something like that, that most of the settings are fairly vanilla for the most part. I think it's those cases where you get acute respiratory distress syndrome or an asthmatic or something like that, that you need to titrate different things. But for the most part, I think it's fairly vanilla when you put a patient on a ventilator. I mean, you might adjust your PEEP depending on your congestive heart failure patient. Like Bert was saying, you might want to start with a lower PEEP with an obstructive disease. But for the most part, I think it's fairly vanilla for the most part. You guys all good? All right, so let's troubleshoot it real quick. So, high peak pressures. Do you guys use the DOPE mnemonic? So it stands for displacement, obstruction, pneumothorax, or equipment failure. So I use the DOPE mnemonic a bunch with the ventilator, so it starts to alarm, and I go through the DOPE mnemonic. So is my tube displaced? Maybe it's down the right main stem, and I'm only ventilating one side. That would definitely increase my peak inspiratory pressure, right? For sure. Maybe it's obstructed, so he's coughing, he's fighting the vent, he's biting on it, right? Or he's got a mucus plug in there. Those would all cause increased peak inspiratory pressures, right? That's a problem with my proximal airways. A pneumothorax would definitely cause that also, or equipment failure. Now, you know, so I might take him off the ventilator and try and ventilate him and see if he's easy for me to bag valve ventilate at that point. I would be willing to bet it's probably not that, but it could be. I would check my plat pressure too, and if my P-plat and my PIP are both elevated, it's probably a lung compliance issue. So like what Mark said, it's a stiff lung. So if they're both high, right? So my P-plat is greater than 30 and my PIP is greater than 40, they're both elevated, then I'm thinking I've got a compliance issue, I've got a stiff lung. So maybe he's a burn patient or he's an ARDS patient or something like that. If my plat is normal and my PIP is elevated, it's more than likely an obstruction. So there you go, right there. So high PIP, low plat on the left, it's a mucus plug, it's a bronchospasm, it's an ET tube blocking, or he's biting on my endotracheal tube. If I got both, ARDS, pulmonary edema, an effusion, or my tube is migrated into a single bronchus. So you guys, again, this is why I really want you to check your P-plat. And your P-plat is not just magic on your ventilator. It doesn't just show up. So you have to check it. But you can see where if my peak inspiratory pressure is alarming, 45, 45, 45, I could have a patient with ARDS and not recognize it unless I mean probably the dude's super sick, but let's say he's pulmonary edema, right? I don't recognize it because I never checked my plat, right? So I ask you guys if you wouldn't mind both. Other troubleshooting, so low volumes could be because of a loss of a circuit, right? So, all of these things, low volume, we used to, back in the old days when the ventilators were a little different, it didn't have a, loss of a circuit alarm. All you'd get was a low volume, and every once in a while I'd show up to work and somebody put their volume down to dash, 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 right? It didn't do that in the old days, it said 0. And so then you'd be like, oh man, like the patient become unplugged from the ventilator or my circuit comes unplugged, and I didn't know if they were getting ventilated anymore, right? Because no longer did it say low volume, low volume, low volume, right? So I would say that it's important to have your low volume alarm set in most cases, and I set it at 10 generally. But there's going to be other indications that your patient isn't ventilating anymore, right? Today, your end-tidal CO2 would be 0, right? You wouldn't have a waveform, which would tell you more than likely. Alright, so yeah, I agree. So asynchrony, I would give some sedation to you, right? So, if my patient isn't breathing synchronous with the ventilator, which is something that you guys will see all the time with your patients, they'll start to wake up. They'll have asynchrony with the ventilator, and that will be an indication for you guys to give some Versed and some fentanyl and possibly reparalyze them. Asynchrony could be secondary to air hunger too, right? So maybe you're not giving an appropriate amount of tidal volume. Maybe you need to adjust your bias flow. Maybe you need to give them a little bit more flow through the circuit so they're not trying to pull in too much. Maybe you need to give them more pressure support. I don't know. Maybe you need to give them more oxygen or adjust your inspiratory to expiratory ratio. If they're having a worsening pulse ox and it's a COPD or an asthma type of a condition, it could be the disease process. Or these are two conditions where I would really look for breath stacking or auto-peeping, like I showed you guys earlier. And with that, these are some things that we're going to do for it. So prolong their expiratory time. And we talked about the ways to do that. It would be to decrease the rate or decrease the I time. Disconnect them from the circuit. Decrease the tidal volume. Decrease the respiratory rate. Or adjust the rise time for a quicker inspiration. So you allow them a quicker type of a breath versus a prolonged. ARDS. Follow ARDSnet. You guys can look that up on the internet if you wish. Confirm the diagnosis. Seek out expert advice. And then, if I were in the emergency room, I'd call you guys to transport, right? So I want CCT down here to help me, or rotor wing, or fixed wing, or some way to get that patient out of there. All right, you guys, questions that I can answer for you about just the basics of putting a patient on a ventilator?